the interest of time, people tend to trickle in a little bit over the next few minutes as dinner finishes or people get home from clinic. I'd love to welcome you all and thank you for your time in coming to this talk tonight, which is from Virtual Specialist Consults in Victoria. And as I was saying to Sandeep, I'm very interested in this topic as well. So pleasure to be facilitating and also learning. We do have Sandeep here, who is a cardiologist and is going to be talking us through calcium scores and valvular heart disease for primary care. Well, I'll leave it up to Sandeep to go through the outline, but we're really looking at what we can do as general practitioners in our office and kind of when we need to probably get some help from a friendly cardiologist. Do you mind going to the next slide, please? Oh, this is me. I'm a GP and a medical educator. And if there's any feedback you have from a GP point of view on the virtual specialist consults, timings of clinics, types of clinics you'd like to see more of, ways we can help access or facilitate your co-consults or case conferences, please feel free to reach out anytime to any of us. But happy to be contacted directly. Thank you. And wherever you're joining us from today, we'd like to acknowledge the traditional custodians of the land on which our health service is built. Those are the Tongarong and Wurundjeri people, and we acknowledge their connection to the land, waters and community in this area. We pay our respect to the people, the cultures and the elders past and present here and wherever you are today. So we usually keep everyone just on listen only. If you want to use the chat function, put some questions in there. We will try and bank them for the end, unless it's something quite really important to bring up at the time. There's the CPD certificate, which will give the survey at the end of the presentation, and I'll put it in the chat as well. And so the webinar is being recorded, and we can provide a copy if that would be helpful. And Virtual Specialist Consults, virtual health specialist service covering across Victoria, and we're really looking to support GPs and the hospital to connect to minimise fragmentation of care. So we have e-consults now. We can write short electronic word note to get simple questions answered. Co-consults, where it's you and the patient, and the hospital doctor, and case conferencing, where it's more of the bigger team coming all together. Next slide, please. I've just gone through those three, but please have a look on the website. We've got information on access and recommended billing and approach. But if any questions, just contact us. Lots of specialties. Always happy to try and facilitate specific times or direct clinics, especially if you're in the country. And so if there's anything we can do to make it easier for you and your patients to work with us, and we can support you, very keen to hear from you. Thank you. And Sandeep's a cardiologist, providing co-consults across a range of cardiovascular conditions in VSC, and actually leads the structural heart team at St. Vincent's Hospital in Melbourne. So love to hand over to Sandeep. Thank you.
Great. Thanks very much for that, Morgan. And thank you to everyone for giving up some time in your evening to coming and learning a bit more about calcium scores and valvular heart disease as well for primary care. Hopefully I'll try to get across the kind of main messages of what we do, what we use these tools to help with, how to interpret them, and when to kind of seek further care. So we'll start off with calcium scores and their relevance to coronary artery disease. Just as a refresher, coronary artery disease starts usually in your teenage years, and it's really a disease of the wall of the artery. So it develops in the intima and then spreads into the media. And with time, these cholesterol deposits just progressively grow and get bigger. And they really take one of two pathways. One is that they just continue to have a very slow progression. And that's how patients end up presenting with stable angina, where they don't have a heart attack, but they just have exertional pain. On the flip side, some plaques will become inflamed and aggravated. And these are the ones that, even though they may not be particularly obstructive, they'll all of a sudden fragment, a thrombus will form on them, and they'll cause an acute heart attack. So the initiation for both of those processes is the same, but they both have quite a different way of presenting. Now, when we see patients, we really tend to have two questions. The first is, does the patient have ischemia? So have they presented with the symptoms that I mentioned, either stable exertional chest pain, or have they had unstable symptoms that may be little clots forming and minor heart attacks? And then sometimes we think about patients who have a lot of risk factors, are sedentary, and maybe don't do enough exercise to provoke symptoms, but we wonder if they have ischemia underlying. On the flip side, more and more we're starting to just ask the question of, does this patient have any cholesterol in their arteries at all? And if so, is it what we'd expect for their age, or is it more or less? The reason why this is relevant, I'll give you an example here. So you've got two patients here. The first one is a 50-year-old who, on the risk score, comes up as an intermediate risk for cardiovascular disease, but they go on to have a positive stress test. And this is what their artery is like. So the artery is this red tube here. And you can see there's a focal bit of cholesterol there that's impinging blood flow through that point. So these patients may have proceeded to an angiogram, had a stent here, and started invasive statin therapy or intensive statin therapy. And generally, you'd expect they do very well because you've treated the area of concern. The rest of the vessel actually doesn't have any disease. On the flip side, if you have a patient who has a similar cardiovascular risk, but their artery looks like this, and instead of having a focal tight spot in one spot, they've just got very diffuse cholesterol everywhere. It's not particularly tight anywhere, but these patients would then go on to have a negative stress test. And in the past, they may have already falsely reassured that there's no concerning coronary disease, and they may not really have intensified medical therapy. And the problem is that patient B is the one that ends up a few years down the track coming in with heart attacks or potentially needing bypass surgery because they have really extensive disease. So the problem with the tests that we were using up till now is that a lot of the tests were looking for ischemia and not really plaque burden. So tests like stress ECG, stress echoes, MIBIs really looked just for whether there was ischemia or not. They couldn't really tell you the overall health of someone's blood vessels. Nowadays, with the introduction of using CT scans more widely, we have the opportunity to actually look at how much plaque someone has and then use that to help guide how intensive we are with our risk factor modification. You'll notice at the last part that angiograms or invasive angiograms aren't actually that good for looking at plaque burden. It's a bit of a subjective score, and I'll just give you some examples why. So when you do an angiogram, the image on the left is the type of picture you see. So here we've got a representation. Remember, it's a 3D image, and we're injecting X-ray dye down this tube into the arteries. And what we see is just a 2D slice of what the vessels look like, but we're not looking at the vessel wall. We're looking at where the blood flow goes. And if you remember, the plaque deposition is actually in the vessel wall. One of the things that happens as plaque grows is that the whole vessel actually enlarges so that the lumen ends up being the same. So you can see here you've got a normal vessel, a vessel that has some cholesterol deposition, a vessel that has a moderate amount of plaque, and then severe plaque. And it's only really between the moderate to severe stage that it becomes obvious there's a narrowing on an angiogram. So you can certainly do angiograms that look completely normal in people that actually have a moderate degree of plaque and not be able to work it out. Whereas the CT scan will tell you that because it shows you the vessel wall. So in terms of looking for plaque, as I mentioned, we use CT, and there's really two methods to go about this. One is to do a calcium score. The calcium score is a non-contrast scan. It uses very minimal radiation, and patients just go in and out of the scanner. There's no need to slow their heart rate down or have any ECG gating. And all we're looking here is there any calcified plaque? In contrast, using a CT coronary angiogram requires contrast. You also need to slow the heart down, and you need to time it with the cardiac cycle. If you imagine the heart's beating and moving around, and you're trying to look at blood vessels that are about 2 to 4 millimeters across, if you don't slow the heart down and give the CT scan time to take an image of a static cardiac cycle, you'll end up with a lot of blurring. With the amount of contrast they give, usually, unless your EGFR is less than 30, that's not particularly a concern. And with the CT coronary angiogram, not only will you see calcium, but you'll also see underlying plaque, and you will get a reasonably accurate idea of whether it's causing any ischemia anywhere. So the reason that calcium is relevant is that coronary artery plaque, as it ages, will generally become calcified. And calcification can be seen actually just on any scan. So whether it's a cardiac CT or whether it's a lung cancer screening CT or a CTPA, we do get an idea of how much calcium is in the arteries. This is what the pictures look like. Basically here you've got aortic root, and this is the left main vessel here, and the LAD coming up and the circumflex going down. And when there's no calcium, you will not see any sparks. And you compare it here to a patient where there's heavy calcification in the origin of the LAD going down here, as well as a diagonal branch. Now, the calcium, obviously we can eyeball it and say whether it's there or not, but there is population studies where they've looked at formal quantification, and that gives us values that you can compare to other people who are the patient's gender and age and see where they sit compared to their peers. This is a slightly busy slide, but I'll talk through the relevant points. So generally, we do calcium scores for patients who are from the age of 40 up till about their mid-70s. But actually, calcium scores can be useful in younger patients as well, really from the age of 25 up. And the most useful cohort to do it is people where they have a moderate absolute cardiovascular risk based on their cardiovascular risk calculators. Now, these are generally patients who have not yet started a statin and are wondering about whether that's worthwhile to do, or perhaps patients who you believe should be on a statin who don't want to go onto one. And that's important because the main thing that you do after you do a calcium score is to decide whether the patient goes onto a statin or not. The benefit of doing calcium scores on patients with moderate absolute risk is that about half of them actually have a calcium score of 0. And if you have a calcium score of 0, your 10-year risk of a cardiovascular event is very low. It's about 1%. So these are patients where you can generally reassure them that there's no need to start a statin. The reason we don't do patients at a high absolute cardiovascular risk is because calcium scores don't show us cholesterol, they show us calcium, which is a surrogate marker. Non-calcified plaque, which is generally the more immature plaque or the newly deposited plaque, doesn't show up on a calcium score. So if you're a high-risk patient, even if your calcium score is 0, there is a risk of you having a reasonable burden of non-calcified plaque, and because of that, we tend to not falsely reassure patients who are in this category. This is the same reason we also don't use calcium scores if someone has chest pain or exertional breathlessness, because even if the calcium score is 0, they may have non-calcified plaque that's causing a problem. You can see in box 1, these are conditions where patients are thought to be at a high risk, so diabetes over 60, diabetes with microalbuminuria, CKD, familial hypercholesterolemia, very high blood pressures, and high total serum cholesterol. Low cardiovascular risk patients generally have low calcium scores, so it's not routinely done just because the yield tends to be low and you end up doing a lot of negative calcium scores. But it is important to note that there are some patients who aren't quite low cardiovascular risk, even if the calculators come out as them. And these are a list of the conditions that you might look at patients, even if their risk factors don't kind of prompt them as an intermediate risk on the calculators. If they've got a family history of premature disease, especially people getting disease in their 50s or less, very high LDL levels, persistently high triglycerides or metabolic syndrome. For women, if they've had premature menopause or things like preeclampsia, patients who have chronic inflammatory conditions, rheumatoid arthritis, lupus, certain ethnicities, so Southeast Asians, Aboriginal and Torres Strait Islanders, and then patients who may have other factors that are abnormal, so a highly sensitive CRP, high levels of lipoprotein a, and peripheral vascular disease. Now, you get a number at the end of the day with the calcium score, and it can be difficult to interpret. And usually what I look at is both the absolute calcium score and where it puts patients compared to their peers. The interpretation that you get is very age dependent. And I'll give you an example here. So if you have a man with a calcium score of 100, and that man is, let's say, 70 years old, that'll actually put him between the 25th and the 50th centile. So his calcium score would actually suggest he has a lower cardiovascular risk than most men his age. On the flip side, if you have a man who's 50 and his calcium score is 100, that puts him very close to the 90th centile for his cohort. So even though his calcium score is not intrinsically a high number, and on this interpretation it puts him at low risk, for a 50-year-old that's actually high risk. And generally, the younger you are, the more benefit you have for statin therapy because it's the years exposed to high cholesterol that's an issue. So you would treat this man very differently based on his age. So I think it's important to look at both the absolute number as well as where they sit in their percentile for age and sex. Generally, if they're 1 to 400 or less than a 75th percentile, there's not a strong push to put them on statin. If they're over 400 at a younger age, or if they're over the 75th percentile for their age and sex, then these are the people that we tend to recommend statin therapy for. Remember, the goal really here is to prevent premature coronary artery disease. When we look at absolute risks, every 75-year-old tends to have over a 20% 10-year risk of death. So it's not that we want to put everyone who's 75 plus on statin therapy. It's just the people that we see as the highest risk in that group. The reason we tend to use statins first is just because the number needed to treat to prevent a coronary event is the lowest for statin therapy. So if you can see here, patients at a high risk, let's say a calcium score over 100, your number needed to treat with a statin is 24. Aspirin is generally less useful, and obviously there's quite a few studies that show aspirin for primary prevention likely doesn't have a population role. This has got to do with the fact that you can have major bleeding with aspirin. Now, in patients that really have high calcium scores and are over the 75th centile, if they can tolerate aspirin, they don't have a history of bleeding, and they don't get indigestion for it, I do recommend it. But for other patients, usually I think the statin is the area where they have the main benefit from. Once you have a high calcium score, that's evidence that you actually have plaque deposition. So not technically, you're not really primary prevention anymore. We use the secondary prevention targets. That would be an LDL of less than 1.8, or as low as possible based on tolerability to statins and ezetimibe. Patients will often ask about repeating calcium scores, and this really has the most utility in those patients who had an intermediate risk and they had a calcium score that reclassified them as a low risk and they didn't start statin therapy. And in those patients, somewhere between 5 and 10 years, it can be worth repeating their calcium score, especially if they still persistently have high cholesterol levels, or they're still smoking, or they've got some other ongoing risk. Importantly, calcium scores do not regress with treatment. And actually, if you put people on statins, what happens is the non-calcified plaque that they had in their system, it tends to mature quicker and calcify. And actually, calcified plaque tends to be more stable and less likely to cause heart attacks. What does that mean? That actually means that if you put people on statins and do a calcium score in a year's time, often the calcium score is actually increased. So that can confuse patients, but it's not actually a sign of harm. If anything, the plaque that they had that was non-calcified and more prone to inflammation and heart attacks is now stabilized. So generally, once you're on statin therapy, there's not much point in repeating calcium scores after that. So just to look at maybe some case studies and how you'd interpret them. First patient is a 48-year-old with type 2 diabetes who came up as an intermediate risk. Now, their Addison score is quite low if you look at the absolute number at 10, but at a 40-year-old, that puts them in the 93rd percentile. So this is a patient with diabetes who has inappropriately early coronary calcium, and they have that puts them on a high centile. So these are patients I very strongly recommend statin therapy. And if they don't have a particular risk for bleeding, I would suggest that these patients take some form of blood thinner. They can take aspirin if they tolerate that. There is some growing evidence that clopidogrel as a single agent might actually be better than aspirin, with lower rates of ischemic events as well as lower GI irritation and GI bleeding. So that's also an option. The only thing that I find with using clopidogrel therapy for patients in the long term is they're coming up to many elective procedures. Often it needs to be stopped, and sometimes they don't have aspirin in the interim. It's a bit more relevant if they've had a stent in the past, but just something to tell patients that if they're just on clopidogrel as a single agent, they've had a stent before, that when they stop clopidogrel for anything, they should usually take some aspirin to cover them in the meantime. If we look at patient 2, a 35-year-old with a family history of premature coronary disease, they come up as low risk because they don't have anything else. They could have an Addison score of 4. And generally, for a patient who's less than 40, whose calcium score is above 0, they have over 2.5 times the risk for a cardiovascular event compared to their peers. So these are patients, once again, where you'd be quite strongly recommending statin therapy. Patient 3, this is a 72-year-old man who comes up as intermediate risk with an Addison score of 100, but at 72, that just puts him in the 40th centile. So this would be someone that you would be reasonably justified to defer statin therapy. Once again, you could consider repeating the scan in about 5 to 10 years. On the flip side, we could look at a 72-year-old man who actually came out as low risk and minimally comorbid, but perhaps he had some calcium on a CT done for another reason, and he had a formal calcium score with a score of 1,894. Generally, if you're over 100, if you're over 1,000, you're thought of as quite high risk, especially if you're not yet into your mid to late 70s. And these are patients where we would recommend statin, some form of antiplatelet therapy. And certainly if these patients either, were physically robust and would benefit prognostically from identifying significant coronary artery disease, or maybe they're very sedentary and they wouldn't push themselves enough to note symptoms. These are patients where we might do a stress test or a CTCA to look for actual ischemia underlying. Just a little bit about what the CT scan actually looks like. So basically, the patients just go in and out of a CT scanner. The actual scan takes about 30 seconds, during which they'll have to hold their breath. Claustrophobia is not usually an issue with these scanners. Now, the pros of using the CT scans, and this is specifically a CT coronary angiogram with dye rather than just a calcium score, is that it really allows detection of non-calcified plaque. And this can be useful in patients who are high risk, where a calcium score may not be accurate because of this, and also sometimes in younger patients where you're looking more for that non-calcified plaque. It gives you I'd say, moderately accurate interpretation of how significant stenoses are. Basically, if the stenosis is very mild, CTs are very accurate. If they're really severe, they're pretty accurate, but the moderate narrowings often get called to be a bit worse than they actually are. That's what we often find. CTs can demonstrate where the disease actually is, and this is important because it's a very different situation if you have lots of disease, but it's at the very end of your blood vessels versus focal disease in your left main, for example. That helps us stratify how urgently patients need investigations and also whether they need an angiogram at all. If they just have small vessel disease, sometimes we will treat them medically and they'll save having another invasive test. CTs can also show you non-coronary artery plaque-related factors, so things like anomalous coronary origins, abnormal vessel courses, and if patients have had bypass grafts, whether those grafts are patent or not. Gives us reasonable imaging of the lung fields next to the heart and also problems in the chest wall, where occasionally we will pick up things like pulmonary fibrosis or lung cancers using the CT scan. On the drawbacks, you do need medication, beta blockers, sometimes ivabradine and GTN. There is a contrast dose, although most patients will tolerate this unless their kidneys are really bad. There is a degree of radiation to it, and occasionally the scans are non-diagnostic because the heart rate still can't be adequately controlled. Lot of interest, these are the types of images that we get. So often they'll do your normal axial scans, and then the radiologists will go through and mark out where the vessel is, and then the software will splay out the vessel, which will give us a very nice view from the very top of the vessel all the way to the bottom. And what you're looking for are calcium specks or cholesterol specks. There's a bit of calcium here in the LAD. This is non-calcified plaque in the LAD, so this vessel is coming down in the mid portion. This test would have come up with a calcium score of 0, but because it was a CTCA, you can see that there's quite a tight narrowing there. Then sometimes you end up with this situation where there's actually just a lot of calcium. And when there's a lot of calcium like this, you can't actually see how the blood flow is in the vessel. The calcium might reflect cholesterol that's just surrounding the vessel or encasing it. In some patients, calcium is actually built up within the lumen where the blood flow is. So in these types of situations, CTCA won't give you an answer, and you'll either need to do a stress test or sometimes an invasive angiogram. Additionally, this type of information is actually very relevant to us. If we did invasive angiogram and we saw that this area was quite tight, knowing there's a lot of calcium there does help us procedurally in terms of determining what equipment we need. So sometimes we will do CT scans to help us decide how best to revascularize patients once we're treating them in the lab. I'm going to pause here for actually any questions on calcium scores or CTs before I go on to the next half of it, which is quite different.
Feel free to unmute. I'll just check the chat.
Can I ask you a question?
Yes, go ahead.
Patient is 86-year-old man with a coronary calcium score of 1080, and has a background diabetes, hypertension, dementia. So, and the patient's on the statin and clopidogrel.
Yes.
So, any other things do I need to give?
No, basically, in terms of your risk reduction, usually from treating the cholesterol, it's, as you mentioned, an antiplatelet and statin therapy. And then if they have high calcium scores, we tend to be a little bit more aggressive in controlling things like their blood pressure, and if they have diabetes, their blood sugar. That's
Yep.
obviously balanced a bit by their age and other comorbidities. And the older you get, the more, I guess you would say, futile some of the treatments become. And if they've got significant cognitive impairment, or they've got, let's say, they're having frequent falls, then you may not be as strict with things like blood pressure control. So I'd say that these tests are most useful for patients really between 40 and 75. They're the ones where we can make quite a big difference in reducing future cardiac events. But
Yep.
patients older than that, they've already developed a lot of the disease process. They've already got extensive plaque burdens. So for
Yep.
them, you're not necessarily changing their prognosis that much. So you start to think about the other factors a bit more in those patients.
Oh, okay. Patient is asymptomatic, and do I need to do the stress echo?
No, I probably wouldn't. Just by what you've told me, I don't think that would change things significantly
Oh,
for them.
okay.
I think they're on appropriate medical therapy, and once you start
Yeah.
getting into your 80s, we're not looking for prognostic disease. We're mainly treating by symptoms, and if they have no symptoms, I wouldn't really do anything further there.
Oh, okay. Thank you.
Yeah.
Including the CTCA, yeah?
Yeah, unless they really had symptoms that were limiting them, then we may do a CTCA to see where their disease is. But
Yeah.
with those comorbidities, I think if they're asymptomatic, aspirin, statin, clopidogrel, statin is plenty.
Plenty. Oh, okay. Thank you.
And I think Deborah had her hand up as well. I might hand over to you, Deb.
Yeah, thank you very much. Just a question about availability and Medicare funding for it in high-risk populations. Is there any program?
So calcium scores aren't funded. I suspect that might happen, in the next few years because they do show quite good utility. But there is an out-of-pocket cost, which I think is usually a couple of $100s. CTCAs, I believe if you have a specialist provider number on the referral, can be bulk billed by certain radiology companies will do it. Some do charge an out-of-pocket cost, but usually there'll be some locally that patients can go to that are bulk billed. I think if GPs do it, there is still out-of-pocket cost for the patients.
Okay, thank you.
All right, thanks everyone.
Sure, no worries. I'll carry on. I think there's one more.
Yeah, we'll do one more and then might carry on. Over to you, I think Arvind.
Oh, hi. Yeah, just a question. How do we decide which one to do between the CT coronary score or the angiogram?
Yeah,
Coronary.
so if they're symptomatic in any sense, so you're worried that they're getting chest pain or they're short of breath, then not this calcium score. The calcium score is not indicated. So in that case, the CTCA. The calcium score is mainly for patients who are asymptomatic, who are in intermediate risk groups. So these are patients where you're worried that they are interdependent, maybe they've got some risk factors that aren't controlled, and whether they should go onto a statin or not. So basically, patients who you think should be on a statin, who have come up at an intermediate risk and are not yet on a statin, it's a useful test to point them one way or the other. If there's any concern that they actually have underlying symptoms or they have underlying plaque, then it's a CTCA. That's the easiest way to look at it.
Thank you.
Okay, great.
Thanks.
I'll continue on. So the next half of the talk is mainly on valvular heart disease and some of the new treatments we can offer patients. In terms of kind of recent updates with cardiology, the field of being able to do keyhole types of procedures to treat different valvular heart conditions has been the main change in the last kind of 5 to 10 years. And there's really been explosive growth in the technologies available and the conditions we can treat, and something that's changing year by year. So basically, we'll go through valvular heart disease, what type of things we can treat and what we look for. And just a note that if you've had patients in the past who haven't been thought suitable for surgery or who thought to be very high risk for treatments, often we can relook at some of these patients now because there are significant progress in what we can offer. The cardiac valves actually all lie in the one plane, and aortic valve here, number one, that's the main thing that kind of causes life-threatening issues. And incidentally, the one that we have TAVI for, which is the most kind of well-studied and evidence-based treatment. The mitral valve tends to be number 2 in terms of how often it causes a problem. And then tricuspid valve we've got here is number 3. And the tricuspid valve is something that in the last year or two as well, there's been a big push to be able to treat those conditions. I'll leave the pulmonary valve out of it because that's often done by the adult congenital specialists, and it's a little bit out of my expertise. Just to give you an idea of what aortic stenosis looks like, this is what a normal aortic valve is like. It's got 3 leaflets, and they usually come together nice and symmetrical. The valve leaflets are very thin and very floppy. The standard degenerative aortic stenosis that we see in patients who are kind of 75 plus in Australia looks a bit like this. So the leaflets thicken, and they have a process that's very much like atherosclerosis, where they get cholesterol deposition, inflammation, and then calcification. And as this builds up on the leaflets, it's a very slow process over many years. You get increased stiffening of those leaflets and an inability for them to lift up. The next picture here is someone that actually has a bicuspid valve. You can see that this leaflet and this leaflet are fused together. And they, instead of getting this kind of Mercedes-Benz type of opening, they end up with just an oval slit. And that puts increased strain on the leaflets. And what they end up with is usually aortic stenosis at a younger age. So rather than being over 75, they tend to be 65 to 75 when they come in with valve problems. Other things are less common where we are. This is rheumatic heart disease, and you can see that there's fusion of the commissures between the leaflets. D is someone with a unicuspid valve, which would usually be picked up in childhood. As your aortic valve thickens, your heart has to work harder to push the blood out. And basically, you end up with left ventricular hypertrophy. Initially, that causes problems with diastolic dysfunction. You get left atrial enlargement. But as this progresses, you start to get fibrosis inside that muscle, and then you can have systolic dysfunction. And when you get to that stage, this becomes a very prognostically significant condition. Now, aortic valve calcification is actually very common, and 1 in 8 patients over 75 will have some degree of aortic stenosis, not necessarily severe, but significant enough that it would be commented on an echo. And as we have an aging population, there's increasing kind of incidence of aortic valve disease through Australia, and they estimate there'll be worldwide, nationwide, about 10,000 cases per year. You may have seen this kind of chart from medical school. It's actually not quite this neat, but basically it just indicates that AS is a condition where patients tend to do pretty well until they start to get symptoms. And certainly by the time they get significant symptoms, so they're reporting chest pain, they've had some form of exertional syncope, or they may have had a heart failure episode, their life expectancy tends to be about 2.5 years on average, so worse than many cancers. So certainly when patients start to come off this perch, we do need to treat them urgently. There is increasing evidence that you do want to treat patients with severe AS before they get significant symptoms, as you can stop them sometimes presenting with life-threatening conditions, and you can also prevent a degree of irreversible heart muscle damage. Now, because it's so slowly progressive, it often goes unrecognized by patients. They don't realize they're limited until it's quite late. Often patients in this age group tend to underreport their symptoms anyway. Heart murmurs often go undetected. Not that aortic stenosis is particularly difficult to hear. It's just that we're all very busy, and sometimes auscultation is not done for a few years. And one thing that has been a problem in the past is that referrals have just been kind of a bit delayed or a bit too late, and we end up treating patients when the risks of doing intervention are much higher because they just don't have any reserve left. Now, as much as we say to auscultate, studies have actually shown that auscultation for valvular heart disease is not particularly sensitive. There was a British Medical Journal study done recently that had a sensitivity of 44% for significant valvular heart disease with GPs, but actually cardiologists were worse at 31%, so worse than flipping a coin. So not that we shouldn't do it, but what we do tend to do now, given that echo is so freely available, is if there's any concern at all that the heart doesn't sound right, is to order an echo. Now, we look at treating patients with aortic stenosis when they're symptomatic, and specifically when aortic stenosis is a major contributor to their symptoms. Now, things like fatigue and breathlessness are common as patients get older for many reasons, but adding everything up, we take a look at the valve severity and how well the rest of their body works. And if we think that treating the AS will improve their quality of life, then that's certainly something we will offer. We do occasionally also look at treating patients with asymptomatic aortic stenosis, and these are the ones where we expect there to be a significant prognostic benefit. Maybe patients where their aortic stenosis measurements are now very severe, their mean grade might be over 50, anyone with LV dysfunction. Sometimes patients that have major elective surgery upcoming, let's say they have a hip operation that they're due to have done, and as part of their workup, they were found to have aortic stenosis. The other condition is sometimes recurrent bleeding. So people with aortic stenosis have a form of acquired 1 Willebrand deficiency. The 1 Willebrand protein is a very long protein, and as the blood gets kind of shot through a tight aortic valve, it can get broken up. And sometimes this will lead to an acquired bleeding tendency. So there have been patients with recurrent GI bleeding without a treatable cause who have aortic stenosis, and then you fix the valve and their bleeding stops. The traditional echo criteria, you don't need to memorize, but things that we usually look at is a mean grade of 4, valvular of less than 1, and a DIO of 0.25. The reason we look at multiple things is that there are errors with measuring any one of these. So there's lots of reasons that an echo can be misleading. Sometimes it's to do with reduced flow state. Sometimes you just don't get a good window. And if your angulation is slightly off, your readings can be quite different. So sometimes we will listen to patients' hearts and think that the murmur sounds very significant. Let's say it's a very long murmur, or they have an absent second heart sound, but their echo doesn't suggest that it's truly severe. We can use supplementary information. Once again, a CT scan can be very helpful. There are formal tools now to quantify the calcium burden on the leaflets, and there are markers for men and women where we know that their prognosis is worse if you don't do valve intervention. And that's something we often do when the valve gradients are low. Occasionally we use transesophageal ultrasound. But certainly if patients are reported to have at least moderate aortic stenosis and they're short of breath, they're having chest pain, and there's no other clear reason for symptoms, we'd certainly be very happy to see them to look at some of these supplementary tests. Now, in terms of treatment options, surgery has been around for many years. Now, TAVI, transcatheter aortic valve implantation, has actually also been around for many years now. I think it's coming up to just over 20. This is what a surgical approach looks like. So it's a fairly large operation, a stenotomy. You can see here this patient's been a smoker, their lungs are full of tar. And day one tends to be the start of quite a difficult recovery process for a lot of these patients. Now, on the flip side, this is kind of what the TAVI incision is like. So we've got here a wire going into the femoral artery. This is a device that we use to put a stitch in so that when we pull the tubes out, we can close up the artery. And that's the type of delivery system that the valves go through. So it's a tube, it's about the size of a pen. Day one tends to look a lot different when you've had a TAVI compared to when you've had surgery, and a lot of patients tend to go home on day one or day two because there's no real downtime. The benefit, especially in older patients, is that they don't lose balance and they don't lose strength, and they can stay active and carry on with the rest of their lives. This is what the actual procedure looks like. So just to orientate you, we're coming up here from the leg around the aortic arch, and this is the delivery system. This particular system has a valve, which is essentially a stent frame that has leaflets sewn into it, and it's mounted on a balloon. Now, we're injecting some X-ray dye here into the aortic root, and this helps us decide whether we've got the valve in the right place or whether we need to push it in or pull it out. A lot of other things going on in this patient, which is pretty standard for the ones we see. So these are sternal wires. This patient's previously had bypass surgery. There's an atrial appendage clip here, and they've had a pacemaker put in. Once we're happy that the valve's in the right spot, we just inflate the balloon. So you pace the heart fast to stop the blood flow. And once that's stopped, the balloon will stay in place. It'll go up with the balloon, and the valve itself will anchor into that calcium that we saw exist there from before. That provides enough friction to grip it in place. Once you're happy that the balloon's up and that the valve's fully expanded, you take the balloon down, and the valve will start working straight away. And then we can stop our rapid pacing and let the heart recover. And the valve will start functioning immediately. We will check to see if there's any leak around it and that the valve's opening properly. And once that's done, the equipment comes out. And this particular type of valve system, you can do the procedure as quick as 15 to 20 minutes. It's not a particularly kind of arduous thing to do. It's very well studied now. TAVI is probably the most studied cardiology procedure to date. the initiation of TAVI was really comparing it to surgery to make sure that the outcomes were as good. It's not just an early recovery you want. You also want to make sure that patients are not having a high risk of stroke or heart attacks. This was the PARTNER 3 trial, which was looking at low surgical risk patients. And it was a composite of all-cause death, stroke, and rehospitalization, with TAVI being the blue line. And you can see, importantly, that there's a reduction in outcomes at the very start. This is very relevant for us because a lot of our patients who are 80, we expect them to have about 5 years of life left. And the most important years of your life tend to be 80 and 81 and 82 rather than 85 and 86. So having a benefit there is important. But looking all the way out to 7 years, there's no evidence that TAVI does worse than surgery. If anything, numerically, the outcomes are a bit better. Valve durability is always a concern when we use tissue valves, and when they've looked at durability, very comparable to surgical bioprosthetics, so a failure rate of approximately 1% per year. With most TAVI setups, you can actually put another TAVI valve inside the one that's failed. It doesn't mean that you need to have surgery down the track. Usually we tell patients that the risk of any serious problems is about 2%. The main thing that most patients are worried about is the risk of stroke. There's about a 5 to 10% chance of a pacemaker being needed. Hospitalization, as I mentioned, usually 24 to 48 hours. And we usually steadily improve recover your activities over the first week. And then after the first week, it's usually back to normal. The government just has a full week of no driving rule, which was really a carryover from cardiac surgery. Patients generally are discharged on an antiplatelet agent, but if they're already on a DOAC for AF, then they just stay on that. They don't need an antiplatelet in addition. You treat them like any other surgical valve, so they usually need to have antibiotics prior to any invasive surgical or dental procedures. Generally, we tell patients to expect their valve to last 10 years. Flip over to mitral regurgitation. Now, mitral regurgitation has taken longer for us to be able to treat, and that's because the valve is more complex. The valve itself is a parachute type of system. The valve leaflets can certainly have problems, but you can also just have an enlargement of the apparatus. So if you have a very big atrium from chronic AF, then the valve can get pulled apart. On the same kind of consideration, if your ventricle is large and floppy from cardiomyopathy, the parachute cords don't work and you can get a leak from that as well. And because there's many different types of problems with the mitral valve implants or new mitral valve valves like TAVI valves haven't yet been commercially marketed. They are coming, but what is available is something called a mitral clip, which I'll show. The mitral regurgitation population is very large. It's actually larger than the aortic stenosis population. And because of the complexities with treating this valve, there's a much smaller proportion that get treated. Mitral regurgitation is also very common in patients with heart failure. So we're talking about HFrEF patients where they have LV dysfunction. And in these patients, having higher degrees of mitral regurgitation actually worsens your prognosis significantly. So a patient with an LV function of 30% with no mitral regurgitation actually can do a lot better than a patient with ejection fraction of 35%, but severe mitral regurgitation. This is due to the fact that the more blood that leaks back, the more filling the ventricle gets, the more it stretches, and then the more the valve leaks again. And you end up in a vicious circle. So these patients, especially when they get LV dysfunction, can be quite sick, and surgery is sometimes not possible, but also after surgery, because all of a sudden the heart's under quite a bit of strain, they have a very long recovery. So to be able to do a procedure that doesn't require them on bypass has been kind of the goal for a lot of cardiology for a long time. The percutaneous treatment, or what we call a mitral clip or Pascal device, these are based on a surgical technique called the Alfieri stitch. And this was done by just suturing part of the valve together. So the valve's like a large smiley face, and usually the leak is limited to 1 or 2 segments. And because it's quite a large valve, you can close off these segments without affecting the valve area significantly. The mitral edge-to-edge repair systems are usually done through the femoral vein. So what we have here is the delivery system going up through the femoral vein. We cross the atrial septum using something called a transeptal puncture. That'll allow us to sit right above the mitral valve. Once you're above the mitral valve, you can position devices, and these devices are used to grab both the leaflets and to bring them in together. Ideally, what you do is grab one leaflet that's not working properly and attach it to a leaflet that is working well so that they seal off the valve at that point and the leak stops. Now, depending on the size of patient's valves, we can sometimes put even up to 4 of these clips on. And we use a real-time guidance with an ultrasound, a TOE camera, to see where the leak is and to see which way to position these clips. So it's very much a tailor-made process to patients. And as such, some of the quick cases are about 30 minutes to 40 minutes, and some of the long cases can take 2 to 3 hours. We usually just spend as much time needed to get the best result we can. The heart's still pumping at all this time. Patients have sedation for the TOE probe, but it's not something that's hemodynamically demanding. And indeed, we sometimes do these procedures on salvage patients who are on lots of inotropes because they're not fit for surgery, and they usually sail through the procedure without any hemodynamic problems. Just out of interest, these are the types of pictures that we get when we're looking at TOE. So this chamber up here is the left atrium. You've got the left ventricle here, and this is the outflow into the aorta. Interestingly, this patient has a TAVI valve. This was a young man with many comorbidities who had aortic valve disease and mitral disease. So the first thing we did was the TAVI, which is here. And then you can see here that this leaflet, the anterior leaflet, is flopping back into the atrium, which it shouldn't. And one of his cords that's meant to tie this leaflet into the ventricle has snapped. So this jet, this yellow jet going up, is all the blood that's getting pushed back into the atrium and back into the lungs rather than going out the aortic valve. So this is a clip device coming in. So we're coming in from the atrium and we're positioning this usually just off center. And what we do is we grab the leaflets, including the one that's flopping up, into this clip and then close it. Now, with the one clip, you can see there's no longer a very large jet going back, but there is still some leak. And that's quite common that you need to put another clip beside. So this is the second clip coming in. And we can see here that we've actually now trapped completely that loose cord that was flopping back. And now there's really not much leak at all, maybe a very small trace leak here. This is someone who actually has an intact valve, but because their ventricles, you can see here, the left ventricle is very large and not contracting well, they have a significant leak of blood through. So this is the group I've mentioned, patients with HFrEF with severe mitral regurgitation, where it really worsens their prognosis quite a lot. This is what it looks like on the TOE ultrasound. What's important to note here is that the jet is very broad, so the area that's leaking is actually quite a large area of leak. Now, despite the fact that the area of leak is very large, this is a result just with the one clip in. You can see that that very large leak has now just come down to a trivial amount. So once again, in this type of patient with a very sick ventricle, surgery would be quite high risk and take a long recovery. Whereas doing this procedure, often they're out the next day, and it's just one venous puncture, which will have a dressing on it for 3 or 4 days afterwards. Now, the things that we look for, just like aortic stenosis patients, are if they're symptomatic. So anyone with severe mitral regurgitation is symptomatic, needs a treatment for it. These symptoms are predominantly shortness of breath, occasionally things like orthopnea, peripheral edema, and uncontrolled atrial fibrillation is also a sign of significant mitral valve disease. Really, on examination, you're looking for a murmur. It tends to be a pansystolic murmur, and it's usually quite loud. The worse the MR is, the louder the murmur tends to be. They may also have heart failure symptoms. Basically, we're looking for an echo report that really says moderate to severe or severe mitral regurgitation. Once we see that, then we're very happy as cardiologists to kind of take it from there. And sometimes we do right heart measurements with a cardiac cath. Occasionally, we'll do a TOE to determine what the best treatment for them will be. So early referrals are generally important for mitral valve disease. With mitral valve disease, it is common to have severe mitral regurgitation and also remain asymptomatic for a long time. But these patients are accumulating cardiac muscle injury slowly. What we don't want to do is to have them end up in a situation where they actually develop relatively significant cardiac injury, because then even when you fix the valve, that injury often doesn't get better and they're left with some permanent cardiac dysfunction. And the last thing I'll talk about is the tricuspid valve. Tricuspid valve has kind of been ignored for a long time, and the main reason it's been ignored for is because there weren't any percutaneous treatments, and surgery for isolated tricuspid valve disease had a very high mortality. So it wasn't that the valve is a benign valve and can be ignored, it was just that really we couldn't do anything about it. Much like the mitral valve, it depends on chordae and it depends on the annulus, and what tends to happen in patients as they get older is, especially ones with AF, the annulus stretches out. And as the annulus stretches out, these 3 leaflets are pulled apart and you develop a leak. Once you develop that leak, the symptoms you get are quite variable. Fatigue and shortness of breath is quite common, but people often will get peripheral edema, they get hepatic congestion and a loss of appetite. They can actually develop cirrhosis. They also can get renal venous congestion, and they can develop CKD from that. So all conditions that happen quite slowly, but cause quite significant impairment to quality of life. And in the end stage with kind of chronic liver and chronic kidney disease have quite a high mortality. Mainstay of treatments is diuretics. So furosemide, spironolactone, and hydrochlorothiazide, we usually add those sequentially. Nowadays, a lot of people get put on SGLT2 inhibitors as well. Patients have pulmonary hypertension. That's the main cause. We try to treat that as much as we can. And if it's from high left-sided pressures, we try to optimize their left ventricular function. But nowadays, we do look at valve intervention. And what we want to do is really not intervene on the patients that already have established liver and kidney disease or keep coming into hospital every 3 or 4 weeks. These patients are unfortunately a little bit too late. What we want to do is treat patients that are just starting to get to that stage. They're the ones that have the most to gain. So people with very large right ventricles where there's a lot of right ventricular dysfunction, unfortunately, some of these have already kind of missed the window for treatment. This is the range of treatments available. Anytime you see a very large range of treatments, it means that none individually are kind of universally effective. So we will tailor the treatment based on the patient's comorbidities, their right heart function, and their anatomy. Some of the new things that have come through that are starting to take place is this system. This is called a trick valve system. For patients where the actual tricuspid valve is too hard for us to treat, instead of treating that valve, you can put a valve in the SVC and the IVC, and these act to shield the rest of the body from the very high venous pressures. And this is done sometimes as a kind of palliative treatment for those very end-stage patients. This is a newer implant, and this is called a Lux valve, and this actually sits inside the tricuspid valve annulus itself. There's 2 little graspers here, and they clip onto 2 of the tricuspid valve leaflets. There's also this plate here, and this plate is pushed against the septum, and there's a little anchoring pin that's fired through it. And you can see that pin up here, and that's what gives it the stability to stay in place. Once again, much like a TAVI, it's done with the heart still beating. This one comes in from the neck. And when the valve's deployed, it starts working straight away. You can see the valve system here, and this is some X-ray dye getting injected into the right ventricle, showing that there's no more leak. So, like the valvular heart disease in terms of when to treat is actually not too complicated. When you look at the guidelines, there's many different criteria, but it essentially boils down to if patients have symptoms and they have severe valvular heart disease, that's almost always an indication for treatment. And if they're asymptomatic, we're watching very closely to see if they're developing cardiac dysfunction. And these include things like enlarged right and left ventricles, a reduction in ejection fraction, pulmonary hypertension, and arrhythmias. So basically, anyone with severe valvular disease, cardiologists generally is involved to keep an eye for these things. And if someone has moderate to severe disease, but they have symptoms and there's no other clear reason you can find, we also tend to want to see those patients because sometimes the echoes can undercall it, and occasionally there's things we can do to help. So in terms of contacting for any of these services, we've got the website for the Victorian Virtual Specialist Clinic, and we can do GP co-consults and e-consults on that. And if there's anything that's particularly urgent, especially in the structural heart space, I have the capacity to treat patients at St. Vincent's Hospital. This is both public and private, as well as Peninsula Private. And we've got email addresses there for my virtual specialist clinic email, which is just sandeep.arnadeeraj@nh.org.au. And for St. Vincent's Hospital, structural_heart@svh.org.au. And there's certainly, if there's patients who are symptomatic and need to be triaged quickly, we can facilitate that. So I'll just stop there and just see if anyone has any questions on any of the structural heart space or the calcium scores.
Looks good, thoroughly explained. Thank you. Might you might just pop to the next slide, which I think is the QR code, if that's all right.
There we go. Yes.
Thank you, everyone. And of course, feel free to contact us or Sandeep, you can definitely go through the consults, but any of these private rooms as well. With if you have anything you want to follow up on, we have our QR code there to register your attendance. We'll just leave it on this slide for a moment. But if there are any last questions or Sandeep, if you have any kind of last thoughts, I think it was
I'll just say
fascinating.
we do treat a lot of rural patients at St Vincent. So I go to Shepparton. My colleagues go to Albury and Wodonga, and we see a few other patients as well. So often we can do the workup for some of these conditions locally. So there are kind of CT scans available in the country. And occasionally we can just do that and see patients via telehealth to stop them having to come in and out of the city multiple times. So these types of services are kind of very relevant for the kind of more rural settings where, to be honest, I think metropolitan Melbourne and suburban Melbourne has quite an abundance of cardiologists and clinics, but certainly for the rural practices, we're finding ways to make it a lot easier for patients. And a lot of these patients are kind of 80 plus, and we understand that it's difficult for them to come into the city. A lot of them don't want to. So if we can just make it for the one attendance for the actual procedure, we do our best for that.
Yeah, so if anyone has any colleagues out in the country who they don't benefit from that, just let them know. I think we have one more slide. Thank you. Thank you. And I think Deborah's got a question. This one's just saying that next month, 28th of July, looking at diabetes in the eye from one of our ophthalmologists. Yeah, but the question is, what is the risk of the mitral clips becoming dislodged after time? Or has there been any research into this or statistics?
Yeah, so the risk of what we call a single leaflet detachment, so coming off one leaflet but not flying off into the body, is about 2 to 3%, and that depends a lot on patient anatomy and how good our visualization is. So usually we'll get a sense of whether that's a risk during the procedure or not. That often doesn't actually cause a problem. The leak just tends to be the same as it was. It's just that you kind of haven't achieved anything. The risk of the leaflet, the device coming off completely, is actually quite low. That would be kind of 0.5%. There certainly are cases where people have fished embolized clips out of the common aortic bifurcation, which can be done percutaneously, but that is quite unusual. The other kind of procedural risks that we watch out for, if people's leaflets are very fragile, there is a small risk of leaflet tears, and that is a problem that can make people worse. So we'll try to screen people out for that as much as we can based on their workup echo, but that is a risk. And the other kind of risk is when people have very bad LV dysfunction, when you stop their mitral regurgitation, it's very easy for the heart to pump blood back into the lungs. It's very hard for the heart to push blood forward. So there is a temporary worsening of LV dysfunction in that first week or so. The people that are really sick, sometimes we will get them in beforehand and put them on some inotrope and kind of baby them through that period. It's very rare for that to kind of end up really in a bad outcome. But overall, the risk for a mitral clip procedure of something significant happening is about 1 in 100. Whereas when you convert that to open surgery in this risk group, that can be, about a 5 to 10% risk. So it's certainly a lot safer. And one of the benefits compared to surgery is that people who are kind of 80 plus, who are starting to get too frail for surgery, but still have a reasonable quality of life and they're still physically active, when they're getting limited by mitral valve disease, it's a really good option.
Thank you. We might wrap it up
just,
there.
Durability. Yeah. Oh, sorry. The other thing is just durability. So durability for the mitral clip beyond 5 years is not particularly known, and that's just got to do with the fact that technology hasn't been around that long. So for patients who are kind of 75 and younger, unless there's a real reason that they're not fit for surgery, we tend to do surgery. For patients that are older, the durability starts to become a bit less of a concern, and it's more about giving them that kind of immediate quality of life that'll last them at least 5 years.
Right. Thanks very much, Sandeep. Fantastic. And we will get in contact if anyone wants copies of the slides. And if you couldn't do the CPD registration because of the chat, or you can't scan the link, that's fine. We can send it through on an email as well. I'll just resend it in the chat just in case, and I'll leave it open for a moment. And thank you, everyone, for your time tonight. There's the link again in the chat if it's helpful. And I hope you all have a lovely evening. I'll stay on this just for another minute or so you can access that link. But thank you all for your time, and thank you, Sandeep.
Great. Thank you very much. Thanks, everyone, for attending.